perkuliahan maupun terlibat dalam kegiatan penelitian dan pengabdian masyarakat. Peluang karir yang dapat digeluti antara lain pendidik, dosen, konsultan kebijakan publik di lembaga pemerintahan, jurnalis, konsultan kebijakan di perusahaan swasta maupun lembaga non-pemerintah, peneliti ahli bidang bioetika, konsultan etika di pelayanan publik, konsultan di komite etik rumah sakit atau penelitian, dan banyak lagi peluang karir lainnya.
Saya Dr. Sigit Kirana Lintang Bima, alumni program studi Magister Bioetika UGM Angkatan Pertama. Menurut saya, bioetika adalah ilmu yang penting dan unik. Kenapa unik? Karena bioetika ini selalu membuat kita berpikir, bukan hanya tentang mana yang benar dan salah, tetapi kenapa hal itu dilakukan. Jadi kita selalu diajari. Semua itu tidak akan bisa saya dapatkan tanpa disertai bimbingan dari dosen-dosen saya yang luar biasa di program studi Magister Bioetika. Bagi saya, yang terpenting adalah bahwa belajar bioetika itu tidak hanya menunjang pekerjaan saya sebagai dosen, tapi juga bermanfaat dalam kehidupan pribadi saya dan selalu berusaha untuk menjadikan saya menjadi manusia yang lebih baik. Terima kasih.
Bergabunglah bersama Prodi Bioetika untuk menjadi ahli bioetika yang mempunyai kepekaan sosial yang tinggi dan menjadi inspirasi bagi masyarakat.
Kalau ada satu pertanyaan, apa sebenarnya bioetika itu? Bioetika itu berkembang dari waktu ke waktu. Yang tadinya etika menjadi biomedical ethics, oleh karena yang banyak menggunakan etika itu kedokteran, medical tadi. Namun demikian sebenarnya pada saat ini yang tidak etis itu tidak hanya kedokteran saja, bisa terjadi di hampir semua bidang ilmu. Sehingga dengan demikian dari biomedical ethics tadi berkembang menjadi bioetika, kemudian global bioethics, ya. Dan yang terakhir yang kita kembangkan di sini, apa yang kita sebut dengan the new sense of bioethics. Ini pun saya mengembangkan ini distimulasi oleh sekretaris UNESCO yang di Paris. Pertanyaannya, Narto, kamu punya Pancasila, tolong etika itu dikembangkan ini. The new sense of bioethics itu adalah satu studi dari transdisciplinary subjek, biologi dan seterusnya, ya. Ada sosiologi, ada economics, ada politik, language, bahkan arts, and is studying of human behavior untuk memiliki in having a new tolerance on transdisciplinary attitude. Apa itu artinya? Memang ada keterangan lebih lanjut, tapi itu setidak-tidaknya batasan dari New Sense of Ethics. Tadinya itu respect for person, beneficence, dan justice. 3. Berkembang menjadi 4. Respect for autonomy, beneficence, non-maleficence, dan justice. Nah, dengan the new sense of bioethic ini, respect for others itu berarti respect pada antar orang dengan hewan, antar orang dengan tumbuh-tumbuhan maupun lingkungan. Ya, jadi dengan demikian respect for others itu ada artinya tersendiri, berkembang lagi. Beneficent, non-maleficent, yang kita tambahkan di situ adalah tidak hanya justice tetapi it should be social justice for all. Itulah Pancasila.
Center for Bioethics and Medical Humanity atau CBMH merupakan bagian dari Fakultas Kedokteran, Kesehatan Masyarakat dan Keperawatan Universitas Gadjah Mada. Sebagai bagian dari perguruan tinggi ini, kami mengemban tanggung jawab untuk melaksanakan Tridharma perguruan tinggi. Kolaborasi nasional dan internasional merupakan kunci dalam melaksanakan Tridharma tersebut. Melalui kolaborasi ini pula, CBMH dapat bertransformasi menjadi sebuah pusat pengembangan ilmu bioetika dan humaniora kedokteran dan membidani lahirnya program Master Bioetika.
Ya, Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera untuk kita semuanya. Senang sekali saya Ririn di sini membersamai Bapak Ibu sekalian dalam agenda rutin kita yang diadakan oleh Pusat Kajian Bioetika dan Humaniora Kedokteran FKKMK UGM. Bangun tidur, tak lupa sarapan. Sarapan paginya dengan ikan. Terima kasih Bapak Ibu yang sudah bergabung di Rabuan dan tentunya salam hormat saya ucapkan. Ini pantun spesial untuk para audiens yang setiap minggunya sudah menunggu Rabuan di jam 1 siang ya Bapak Ibu sekalian. Terima kasih sekali sudah bergabung dan saya juga turut menyapa di sini ada Prof. Hakimi. Terima kasih yang selalu mensupport dan bergabung di Rabuan dan juga Romokus dan Bapak Ibu sekalian yang senantiasa membersamai kita semuanya di CBMH UGM. Dan
Selamat siang, Mbak Wahyu.
alhamdulillah sehat selalu,
Ya,
Romo.
sehat.
Alhamdulillah, terima kasih Romo. Ya, Bapak Ibu sekalian, saya juga akan menginvite satu speaker kita dari Universitas Erlangen, Germany. So I would like to invite Dr. Hadil. Hello, Dr. Hadil.
Hello.
I'm so glad to see you in this Zoom meeting. I hope we can directly meet in next time, yeah, Dr. Hadil, in Yogyakarta or maybe in Germany.
Maybe.
Okay, nice to see you, Dr. Hadi. I hope you're in a healthy condition in Germany. Good morning in Germany, right?
Thank you. Yeah, it's 8 o'clock.
Okay, Dr. Hadil already completed her PhD degree in February 2023. So it's very great. Congratulations for that. And now her activities is doing some research project and also teaching undergraduate and postgraduate course in University Erlangen, Germany. I'm sorry, maybe I have some mistakes for spelling your university. And she is very concerned in nutrition in end of life. So some of research that already published in journal that talk about terminally illness and nutrition in end of life. So maybe if you want to access more and read more about her publication, you can just write down her name in PubMed on others. You will find many papers that talk about that. And she is also co-editor of the Journal of Medicine, Ethics, and Islam. So, Dr. Hadil, I believe this is very important and very interesting to talk about withholding or withdrawing artificial nutrition from terminally illness patient, and it really poses challenges. We discussed with Dr. Hadil about that, and I believe we will get many important information about that case, because we will discuss about tube feeding in dementia from an Islamic perspective. Time is yours, Dr. Hadil. You can share your PPT.
Thank you. I hope you can see all the presentation. Is it
Yes,
visible?
it's great.
Okay.
Yes.
Yeah, all good.
Thank you. Thank you for your kind words, and thank you for the invitation to the Rabwan Forum. I first want to note also that I'm a researcher in the fields of Islamic theology and have no background in medical, no medical background. So that's very important for you maybe to know where I am come from in academia. Yes, nutrition at the end of life is, in the context of dementia, is highly contested. Dementia is an organic disease of the brain, and common features of different types of diseases, such as Alzheimer's disease, cause the progressive deterioration of cognitive function of the memory, which is linked to communication, personality change, and motor disorders. Especially in the terminal stage of dementia, is characterized by swallowing difficulties or loss of appetite, which lead to weight loss and dehydration. A more frequently medical procedure in this case is artificial nutrition and hydration, which can be given through gastrostomy or gastrostomy tube or a nasogastric tube. So first, I want to give you a short overview, a brief overview on the dementia disease and the stages, especially the terminal stage. And then I will introduce you to the disadvantages and advantages of artificial nutrition and hydration at the end of life from a medical view. And afterwards, I will analyze the discourse in Islamic theology and the Islamic context on this medical procedure, and I will also analyze the arguments they are using. This presentation is based on the open access contribution, on my open access contribution, artificial nutrition and hydration in the terminal stage of dementia from an Islamic perspective. First of all, I want to introduce you to this most common symptoms of dementia. The common features of the different types of dementia, such as Alzheimer's disease, cause a progressive deterioration in cognitive and memory functions, which is associated with communication problems, changes in personality, and motor disorders. The symptoms intensify as the disease runs its course, and the person living with dementia needs increasing level of care and support. People with dementia lose abilities, but with assistance are still able to use those who retain. Dementia is an umbrella term that refers to a large numbers of types, such as the Alzheimer's disease, which is the most common form of dementia. There are also other types, such as the Lewy body dementia. At the early stage, the patients face problems with short-term memory and have mood swings, along with experiencing word-finding difficulties. Communication increasingly is challenging. Further early signs are difficulties with solving problems and performing daily tasks, such as cooking meals and driving a car. And the affected patients are aware of the changes and often withdraw from social life or conceal their difficulties from others. For this reason, relatives, friends, and the individuals themselves often misrecognize this stage and may consider the patient to be suffering from depression or simply experiencing the effects of older age. In the middle stage, it is no longer possible for the individuals to conceal the changes because they find themselves experiencing considerable difficulties in everyday tasks and personal care. The impairment of long-term memory increases, but actions learned early in life remain available and can be used in the individual's care. People at this stage can live semi-independently with assistance provided. People with late-stage dementia are often bedridden and their speech is impaired, which makes articulation virtually impossible. They are typically unable to walk or to feed themselves. They are incontinent and aphasic, and they have lost the capacity to have relationships with other people. In addition, difficulties in swallowing or incontinence occur. Loss of appetite and desire for food is likely to lead to lower food intake, malnutrition, and consequent weight loss, and ultimately leads to difficulties for caregivers in ensuring they take in a sufficient amount of food and liquids. Assistance with eating counters malnutrition in moderate dementia. However, artificial nutrition and hydration is an option at the late stage. In many cases, people in this terminal stage of dementia die from infections, and it should be noted that death certificates in many countries do not record dementia as a cause of death because of the difficulty of assessing whether dementia or the accompanying illnesses were the cause of the key causal factors. First of all, I would like to examine artificial nutrition and hydration at the end of life from a medical view before we analyze Islamic opinions on it. Food intake, swallowing, and drinking are considered among the last everyday activities to be impaired in people with dementia. The results are malnutrition, difficulties with swallowing, and food refusal. In the advanced stage of this disease, people with dementia no longer know what they are supposed to do with the food or the utensils put in front of them. Behavioral problems emerge and eating skills are lost. Studies show that a low BMI increases the mortality of people with dementia. However, food refusal may additionally be related to other factors. For example, a distracting environment, for example, or a poorly fitting dental prosthesis causing pain or gum inflammation may impact food intake. In advanced dementia, functional impairment in swallowing leads to aspiration before, during, and after swallowing. Dysphagia causes choking and increases the risk of pneumonia, which when bacteria enter the lungs. Pneumonia is one of the common causes of death in people with dementia. A medical procedure that is finding more and more use in this case is artificial nutrition and hydration, which can be given through a gastrostomy tube, or a nasogastric tube. The latter is used to bridge temporary periods of insufficient nutrition consumption. However, there are drawbacks of this treatment. As soon as it is foreseeable that tube feeding is needed in the long term, the patient receives a PEG, a percutaneous endoscopic gastrostomy, after considering the individual case, of course. Furthermore, artificial feeding is claimed by some physicians to satisfy hunger. For example, the physicians Muhammad Ali Al-Bar and Hassan Khamsi Pasha argue if hydration and feeding is stopped, the patient does not die peacefully and comfortably. He suffers dehydration and hunger for 10 to 14 days. They recommend reducing the amount of nutrition at the end of life and justify that the reason for this approach is to prevent the potential feelings of guilt and sorrow that could be experienced by the family if nutrition and hydration support was withdrawn or withheld completely. Studies in palliative care show, however, that many persons at the end of life do not feel hungry and thirsty, and consequently do not starve. A dry mouth is not in and of itself a sign of thirst. The dying person may suffer from a painfully dry mouth, and oral care is essential to alleviate this suffering. In fact, dehydration and reduced food intake support the dying process because they aid to release endogenous opiates in the brain, which is likely to make the patient's state more comfortable. The request for treatment at the end of life, such as ANH, artificial nutrition and hydration, reflects a strong hope in its effectiveness, but the survival rate with ANH is controversial. Compared to assisted hand feeding, Joe and colleagues show that nasal feeding could not significantly lower the mortality rate in late dementia. Proponents of this therapy argue that ANH reduces the risk of pneumonia. However, Joe and his colleagues have shown that there is no significant evidence that ANH decreases the incidence of pneumonia. Another problem with ANH is its elimination of the social component of food consumption. Joe et al. Suggests that tube feeding leads to isolation and that an adequate environment setting, for example, removing distractions and scheduling mealtime with family, could make patients enjoy their social time as opposed to isolated tube feeding. Considering that food intake is one of the last activities people with dementia can undertake in the context of their loss of cognitive skills, the withdrawal from social life, which may take place with artificial feeding, is a concern. Therefore, Muriel Gillig recommends oral food intake for people with dementia in the terminal stage of their disease. Further disadvantages of artificial nutrition outweigh its few advantages in the dementia context. Artificially fed dying persons have stomach and bowel content, which leads to vomiting, nausea, and diarrhea. They suffer pain and discomfort during connection, repositioning, and disconnection of the tube. Tubes may become blocked or infected, and fixation is needed to avoid the patient manipulating them. Other side effects are risk of bleeding and trauma to abdominal organs, whose prevention may necessitate the use of constraints and chemical sedation. Moreover, changing the tubes requires an invasive procedure in a hospital, which can be stressful in advanced dementia. Swallowing problems can be treated by non-invasive methods. There are 3 ways to encourage independence in eating: assisted hand feeding, which means assistance with eating and drinking, or adjusting the setting of meals and the position of the patients during feeding, and the modification of the texture of the food texture. First, assisted hand feeding, that is the assistance of another person with food intake, is a favorable alternative to ANH. Assisted hand feeding, AHF, requires nursing staff or carers as opposed to medical intervention, and therefore represents an instance of interpersonal interaction for people with dementia. This form of food intake is time-consuming and makes significant demands on staff or caregivers' time, which engender a high cost in staffing or in loss of earnings for the economically active caregivers. When AHF is possible and the person ingests enough food, from a medical point of view, ANH is not necessary. In cases where AHF ceases to be viable or food and or liquid intake is insufficient despite AHF, artificial nutrition and hydration can be considered, provided that its benefits are likely to outweigh any potential harm. The oncologist Shabir Alehbai contends that assisted hand feeding is often not possible at this stage, and maybe the question arises whether assisted hand feeding is unfeasible due to swallowing problems or impractical due to the lack of staff or care resources for the more time-consuming process of AHF. The second alternative, a noisy environment may be distracting to the person receiving feeding, and their physical position and posture affect their swallowing function. For example, the chin tuck position and head rotation towards the weaker side can facilitate food intake. And the third alternative, swallowing problems can arise from the texture of the food offered, where it is required to do physical effort when chewing, and liquids are too difficult to control. And modification of the physical features of the food, such as mashing and thickening and foaming, can make food appetizing and serve an opportunity to increase enjoyment when eating, as well as countering the swallowing difficulties. Difficulties with swallowing can be treated by invasive and non-invasive methods. The latter are preferable but not always possible. However, the medical and psychological side effects of ANH should be also considered. After we have examined now the medical sides of tube feeding, we analyze now the treatment from an Islamic point of view. Clearly, starvation is ethically an unacceptable route. Offering too little food can be viewed as neglect, and relatives in particular may feel a sense of co-responsibility for the death of their family member. Some relatives may understandably opt for ANH to avoid feelings of guilt at inactivity in the face of their loved one's state, which may overcome them if they withhold or withdraw ANH. Notably, Alba and Khamsi Pasha disagree with the complete discontinuation of basic nutrition because this would mean starvation to death, which is a sinful act from an Islamic view. As I have mentioned before, studies in palliative care show, however, that many persons at the end of life do not feel hungry and thirsty and consequently do not starve. Al-Salami, the physician Sami Al-Salami, contends that the complications of ANH, as I detailed before, should be accepted as the lesser of the two evils, due to the greater harm from a religious point of view caused by responsibility of the person's starvation. The Islamic Fiqh Academy, affiliated with the Muslim World League, declared in 2015 that continuing feeding is significant for the care of the patient. Hence, refusing or withdrawing ANH would be equal to quasi-intentional homicide. This conclusion derives from the following precedent of the prohibition of killing detainees, qatl al-sabr. It was reported by Khalid ibn al-Walid that the Prophet Muhammad prohibited to confine someone to die. The analogy is questioned because the underlying situation differs. The killing of a detainee is an active act which certainly leads to death. However, the analogy of qatl al-sabr is contested in the case of the refusal of ANH when no tubes are placed. If the person or his relatives decided not to undergo ANH, then refusal of this is permitted because refusing a medical treatment not guaranteeing to prevent death is not forbidden. For example, a fatwa released in 2017 states that refusing treatment from fatal disease is not considered suicide. Whereas if they wish ANH to be administered, then it is permitted too. In a nutshell, the analogy has shortcomings. The intention, the niyyah, the intention in the precedent is to confine someone to die who would normally continue living if not confined. Whereas the intention in refusing or withdrawing ANH is to let someone die who has no chance of improvement with any medical treatment. So there should be made a differentiation between killing, which is qatl al-sabr, and letting die, the refusal of ANH. Another argument which is brought is actually ANH a medical treatment or nutrition. It is debated whether ANH is considered a medical treatment or a kind of nutrition at the end of life. The Islamic scholar Yusuf al-Qaradawi argues that if therapeutic substances, for example, nutrition in the form of an injection, extend the duration of the illness and suffering, then it apparently is neither obligatory nor preferable. It becomes obvious that Al-Qaradawi envisions a different approach on biomedical dilemmas, weighing up the benefits against the potential harms of a specific medical procedure. Interestingly, the same controversial discussion on artificial nutrition and hydration can be found in Judaism. On the one hand, for example, Rabbi Moshe Feinstein and Rabbi Shlomo Zalman Auerbach contend that ANH is imperative and may be administered involuntarily, even if the patient is suffering from it. On the other hand, Rabbi Herschel Schachter and Rabbi Horowitz argue that ANH is a medical procedure which may be rightfully be refused by terminally ill patients. And the last argument, the duty to feed, but whom? Proponents of ANH argue that the refusal of artificial nutrition and hydration would lead to death by starvation. Islamic scholars and physicians are therefore inclined to allow artificial food intake when the patients are not able to eat and drink by themselves, as I mentioned above and before. The view outlined above ultimately stems from the Quranic directive to save life, as expressed in numerous verses on the duty to feed the poor, the hungry, the needy individuals. And it is obvious that this imperative implies to giving drinks and food, and could be interpreted as a basic human right to have access to food and drink. But thus, this duty to feed also applies to or implies a artificial nutrition and hydration. Does the duty to feed apply also at the end of life when the dying person refuses food and liquids? The dying person does not feel hungry and thirsty because this is a part of the dying process, while the non-dying person aims to survive. Furthermore, the question remains who is meant to be provided with food. Here, the person in need of food lives in privation and has no access to it because of financial reasons, for example. In the final analysis, the Quranic duty to feed, who's the duty to feed those wanting to be fed, cannot be applied at the end of life context. According to the Islamic tradition, there should be no constraints placed upon the sick person. Ibn Qayyim al-Jawziyah refers to a hadith who states that one should not force sick people to eat and drink because God gives them food and drink. Referring to the hadith which discourages forcing the sick to take food and drink, I argue that refusing ANH is permissible. Artificial hydration and nutrition at the terminal stage of dementia should not be the preferred therapy from a medical and an Islamic perspective, respectively. ANH can be a reasonable intervention for short-term use in a situation where a person with dementia has lapsed into a coma or is unconscious. However, ANH should not be obligatory in the terminal stage of dementia if the patient or the relatives refuse it. Hence, it is crucial that at least two physicians agree upon the dying phase having started and any treatment being futile. I therefore strongly advocate the provision of greater resources for assisted hand feeding and palliative care, particularly in the light of the argument, which I hope to have supported in this presentation, that the disadvantages of ANH at the terminal stage of dementia outweigh the benefits. Besides the medical considerations, the ethical arguments from an Islamic perspective have been discussed on this three topics. In my view, the president of the prohibition of killing the detainee, the argument of Qatl al-Sabr, cannot support the ethical deliberation of ANH. Furthermore, the Quranic imperative of the duty to feed may apply only to the terminal ill dementia patient who still shows interest in food and can eat with assisted feeding rather than with ANH. Where a patient with dementia does not wish to eat with assistance, the duty to feed does not apply, because the Islamic perspective would consider force feeding non-permissible. Instead, the patient's comfort should be ensured and pain relief provided if the patients or the stakeholders request it after an informed consent. The Quranic duty to feed cannot be applied in the end-of-life context, and the majority position in the Islamic scholarship agrees that there is no moral responsibility for the death on the physician or the family members. At the terminal stage of dementia, weight loss, decreased food intake, and food refusal and swallowing difficulties signal the approaching end of life. From an Islamic ethical perspective, acceptance of this dying process is permitted. Letting the patient die in futile cases does not interfere with the moral duty of the physician to save lives. The duty is rather to allow the person to die with dignity. On this note, I will conclude by stressing the ongoing need for intensified research in palliative care to the end of raising more awareness on its effectiveness, necessity, and permissibility. For your information, this is the literature which I used, and thank you so much for your attention.
Thank you very much, Dr. Hadil, for your insightful information, and I believe this is very important. We frequently face that case, I think, in hospital or maybe in a home care case. So sometimes we think that giving to feeding may be full deal and also reduce, of course, sometimes reduce their quality of life, right? Because of the side effect and the process itself for a patient. And many information also delivering by Dr. Hadil. So I will invite Bapak Ibu sekalian that maybe want to ask or maybe discuss more with Dr. Hadil. Maybe you can